Thanks so much, and I'd like to thank the organising committee, President, Chancellor, and distinguished colleagues and guests. So I'll be brief as well, because I know we're running short on time. So I hope you could see my slides. So I'm here at the National Hospital in London, and we learnt very early on from the reports in China, and then, of course, in Italy and France, how the pandemic was starting, and early on, how neurological adverse effects were seen. And we knew that the virus has the potential to infect brain cells, so this does remain slightly controversial, through the ACE2 receptor. But also a burden of psychological disease, anxiety, post-traumatic stress disorder, that's also been seen with previous epidemics. So in the summer of last year, we reported on what our hospital was seeing, where we were looking at cases that were referred to us. So there was referral bias of mainly hospitalized patients who had been admitted with COVID, who had neurological complications. And we saw four main patterns. And we saw people with an encephalopathy, confusion or delirious state, often younger people than one would expect. And this can be transient. And by definition, we found no evidence of permanent damage necessarily on brain scans. And again, inequity is exposed here, as there are only certain places where you could have detailed brain scans or MRI. We then saw a group of patients who looked like they had features of inflammation, though there were some vascular features there, stroke, and then a miscellany, including peripheral nerve Guillain-Barré syndrome. Now, these are patients who had encephalitis, which looked immune, and then an encephalitis which had features very similar to the acute disseminated encephalomyelitis that's been reported since the 1920s. Though thankfully, and there may be many reasons for this, we seem to be seeing less of this now with the more recent waves. And very rarely we've seen necrotizing encephalitis where there may be viral induced cell death in the brain. But we could see swelling of the brain requiring surgery to remove pressure. And the pathology shows inflammation in those cases and not virus. And then these are patients with stroke, often younger people who had disseminated blood clots. They could have blood clots in the lungs and in the brain. We thinned the blood for the first stroke, and then they have another stroke. So it was a very striking pattern. And I'll show you in a meta-analysis of cases, hospitalized cases across the world shortly, that stroke remains the most disabling neurological effect. Some features that we found last year in the end have not been as large or great in proportion as we had thought they would be. So for example, the Guillain-Barré syndrome, given the vast numbers of people who've had COVID, we haven't seen our hospitals inundated with Guillain-Barré syndrome, and the association is less secure. It probably is a cause in some, but you can see here that we had fewer cases of Guillain-Barré syndrome in the last year, perhaps due to lockdown suppressing other circulating viruses and conventional causes of that syndrome. And the story of neuropathology emerged in that time. These are postmortems carried out at our hospital from cases, people who died of bad COVID, systemic COVID and lung disease in intensive care. If you look at their brains, you see infarcts, you see microvascular disease. And then this pathological series from Germany, you again see vascular disease, infarcts, but also some activation of the innate immune system. And emerging hypotheses of what is the mechanism of this are, well, could there be direct cell invasion? There was, of course, concern with anosmia. Could the virus be coming up through the nose, the olfactory epithelium, and going into the brain? There was a report this week that suggested that wasn't likely. And in fact, the virus may affect the basket cells and supporting cells in the olfactory epithelium, but not the neurons. But certainly in one report, Akiko Iwasaki and her team have shown that the virus has been seen in postmortem in the cortex of humans, can infect brain organoids. And there may be other mechanisms in the body, raised inflammation, type 1 interferon response in the brain. That's not seen so much in this model, yet the virus seems to choke off the oxygen supply from adjacent brain cells through hypoxic inducible factors. So the emerging story of how can COVID affect the nervous system is, well, there's systemic disease. That's, I think, is going to be the main one, with a coagulopathy and stroke, and the effects of encephalopathy on the brain. Cell invasion, brain invasion, still unknown how much this is going to be a problem. And of course, this is important in the long term. I haven't mentioned nerve and muscle involvement for those who've been in the ITU. Certainly in long COVID or the effects of COVID, many people have muscle weakness, and in theory, there could be mitochondrial and other effects there. And then the inflammation of the brain that we've seen actually now less commonly than we were expecting. This could be an immune mediated mechanism. It comes on after the initial infection, and that's where we see the encephalomyelitis or autoimmune encephalitis features. In this meta-analysis with Laura Benjamin, who's with us today, looking at 4,000 hospitalized patients across the world. In this study, it's bad news. So a third of patients would die at 30 days who had neurological involvement. Half of them had encephalopathy, a quarter stroke, 40% in the ITU. And you see, using the modified ranking scale, that the burden of impact is in those who had stroke rather than the encephalopathy, which was transient. But it's also seen that those from lower middle income countries had a worse impact and a higher mortality than those in higher income countries. So long COVID, again, we don't have time to talk about this, but again, what is due to ongoing viral persistence, immune effects, or are we seeing other factors in those who've recovered? Certainly the majority of people we see in the clinics now were never admitted to hospital. And this is an area of study. A couple of studies we're running in the UK, as one looking at the COVID CNS study, looking at hospitalized patients and their complications. And then a STIMULATE study looking at those mainly non-hospitalized, and both of them looking at biomarkers, brain imaging, and other factors to try to figure out what's underpinning these problems. So the elephant in the room is, what are the long-term effects going to be? One study here from colleagues in Oxford, looking at 250,000 US medical records, so very low granular data, could see that perhaps there's a double risk of Alzheimer's disease after COVID, but that was enriched in the 40,000 of those 40,000 patients, of those among them who had encephalopathies, and does not necessarily mean that the virus is causing Alzheimer's disease. And it may be those who would have had that diagnosis anyway in the next year or two, went through the stress of having COVID and then manifested their symptoms early, having had that delirium, which is a common story. But of course, this needs follow-up. There's something about this virus, unlike influenza or other reasonable historical controls. This UK biobank and brain imaging study looked at healthy individuals who had brain imaging and memory testing at baseline, and then 400 or so went on to have COVID, and they were retested compared to 400 or so who didn't have COVID. And there was some evidence of regional atrophy in insular and orbitofrontal left hemisphere regions, and some impairment on mainly attentional subcortical memory testing. Again, these could likely be plasticity changes. So we have to be careful that we're not saying, we don't yet have data that shows that this is an illness, a virus that is directly infecting the brain or through other mechanisms causing a progressive neurodegenerative process. We don't have evidence of that, but to be reassuring, but we do need to invest and study this further. And a problem with inequity there is that it's very hard to do this in public health where detailed brain imaging and memory testing is not available. And again, are we going to see what we saw 100 years ago after the 1918 pandemic? Are we going to see a delayed onset of degenerative neurological disorders, Parkinson's disease, encephalitis lethargica? Well, at the moment, given the volume of people who've been infected, the better science, the better brain characterization that we have now, we haven't been seeing, as I've shown you before, large numbers of cases of encephalitis, but we do need to be vigilant, and we can learn from back then in many more ways. I recommend this book by historian Paul Foley that looks at the history of the 1918 pandemic and encephalitis lethargica over the 30 years after that pandemic, and many challenges in society and politics there that are instructive to us now, and a book by Joel Walensky, which has self-reported accounts of people, including physicians, who had the illness. But the key thing about COVID, I think, to quote Michael Marmot, who's had a report in the UK, is that it's exposing and amplifying inequalities. And to quote him again, the heart of what we should do is to redress those inequities and to enable a fairer distribution, not only of vaccines, but I think prevention of infection and illness, but then for those who have neurological or psychiatric symptoms where there is often extra stigma, fairness and equity in treatment. So I'll stop there. There are many people in the UCLH COVID service and brain infection and immunology group, and thank you for your time.